This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Good morning, everybody. It's an honour to be here today, and I'm the sepsis lead as part of the Deteriorating Patient Programme at the Clinical Excellence Commission. But all of my team colleagues are here today, some of them in the room, some not. So I'd like to acknowledge them because they're just as much part of this. And I can also recognise a few faces around the room of people who are involved in the programme in New South Wales. So you deserve just as much acknowledgement, because without you, I wouldn't be standing here. So thank you. So just to set the scene in the context of the Clinical Excellence Commission, it's one of 5 pillars that are responsible in New South Wales for leading quality and safety improvement in our public hospitals. And the Sepsis Kills programme is one of around 30 large system change programmes. New South Wales health system is divided into local health districts, and we have our hospitals which range from large tertiary referral hospitals down to the tiny multi-purpose services which often don't have a doctor on site, so it's pretty diverse. Sepsis, as we know, is an international problem. I think in the last day and a half we've been around the world numerous times, and we're hearing time and time again that sepsis is a leading cause of death, and it's one of the most common causes of calling a rapid response. Despite that, often outside of an intensive care environment or an emergency department environment, the clinical staff are not aware of how devastating sepsis can be. And it often isn't considered initially. And as we heard with Imogen's presentation and numerous other presentations, we just don't think about it until it's possibly too late. And a couple of examples that came up during the life of our programme. It's Rory Staunton in New York, who had a minor skin injury. He went to the emergency department. They thought he was dehydrated, gave him fluids, sent him home. He came back the next day in septic shock and died. In New York City, there's now legislation that anybody presenting with a known or suspected infection must be screened for sepsis. A little closer to home is baby Elijah Slavkovic. He hails from Melbourne, and he took his first and last holiday to the New South Wales south coast, aged 3 months. Gained sepsis. He had multiple transfers to other facilities. Sepsis was considered, but it wasn't in a timely way. His case was one of the ones that formed our case for change back in 2009, 2010. Prior to that, there'd been 18 months of collecting incidents from our incident management system, which showed that there was a failure to recognise and manage sepsis appropriately in a timely way across a variety of facilities and across a range of clinical units, so not just emergency departments or the wards. And overall, there was a failure to manage sepsis as a medical emergency in the way that you would manage trauma, stroke, acute coronary syndrome. And the clinical focus report that you see there on the screen is available on our website, and that details many of these cases. This audience would be very familiar with the challenge of sepsis. High morbidity, high mortality. It happens really quickly. It's a difficult diagnosis, particularly with the young, the old and the immunocompromised. Despite that, we're still not getting it right. So the CEC was after that clinical focus report, was given the task of fixing things. And so we came up with the Sepsis Kills programme. It's actually the clinicians who've called it Sepsis Kills. We branded it in our logo and had a very long name in the first instance, but they just referred to it as Sepsis Kills. It's a very simple programme based on the current evidence of the time. So the Surviving Sepsis Guidelines 2008, but subsequently changed to 2012. 3 simple actions. Recognise the risk factors, signs and symptoms of sepsis, and really importantly, involve a senior clinician. Resuscitate with intravenous antibiotics and fluids, and refer to specialist care and initiate retrieval. Particularly important in those smaller hospitals where retrieval needs to be thought of very early, because by the later stages, by the time you've organised the ambulance, the air, whatever you need, it's too late. The programme is fully integrated with Between the Flags, and you've probably heard lots of references to that programme over this day and a half. And that programme is based around some standard observation charts, single parameter, track and trigger, and the charts are used from newborns right through to the older people. The red and the yellow colour zones on the SAGO and the other charts correspond to our sepsis pathways. And again, working with the Between the Flags system, which was rolled out in the year before sepsis, we use the same governance structure. And what we actually have is combined sepsis leads at both local health district level and facility level who often are doing both BTF and sepsis, and it works really neatly. And it's forever pushing that message that sepsis is just one of the many, many causes of deteriorating patient. And that's been very helpful for us so that the clinicians don't sort of slump and go, oh my God, another program to take on board. It's just part of the system that's already the safety net for New South Wales hospital patients. The other standards I'll just whip through very quickly and show you some of the items from it. Standard clinical tools. We have pathways and empirical antibiotic guidelines and a number of other tools, but I'll just focus on the pathway. Essentially, they're based on those three actions. So recognise is the first page, resuscitate is a 2-page internal part of a 4-page document, and finally refer on and then a 48-hour management plan. It's really important that we want the clinicians to think about sepsis. We really can't tell them everything to do in a medical form. It does go in the medical notes and carry through, so it's great for communication, but it only tells you certain things. It's not prescriptive, and at the bottom line is that clinicians need to maintain their own clinical judgement. Don't say, it didn't tell me to do it on the pathway. And that's where the senior clinician and escalation is really, really important. Just as life's gone on, we've developed other pathways other than the adults. So we started with adults in the emergency department. We've then added in paediatrics, and more recently the maternal and newborn pathways. All of them have this common theme of escalating to a senior clinician. And the senior clinician will depend on the hospital that you're in. So in one facility, a rural facility, there is only one doctor to call, and he may or may not be on site. In a bigger facility, the senior may be the registrar, or it may be the attending medical officer. But the important thing is that that person is involved early, both with confirming that the patient does have sepsis and should go ahead and have antibiotics and fluids, but also making sure that other resources are pulled in appropriately. Obviously, time is critical, and we know from the RCAs there were many instances where a junior doctor was doing every investigation under the sun before he or she called Sir or Mum to seek extra advice, and we don't want that to happen. Often these patients are quite sick anyway, so if it isn't sepsis, they do need that senior to take a look at them. The resuscitation phase, we've kept it really simple, and it's really about getting the first lot of antibiotics and fluids in. And with the antibiotics, I'll just say, reflecting yesterday, one of the presenters put Kumar 2009 up that showed if you don't put the right antibiotic in, then you've reduced their survival down to about 10%. So really important. But one of the unintended consequences of the program has been that everybody's rushing to give antibiotics. And sometimes there does need to be a little more consideration, particularly if they're in the yellow zone, you've got a little bit more time. And we're in the process of revamping the pathway just to reflect that a little more clearly. We have lots of education resources. We've fully integrated the program into our DETECT program, so 60,000 staff across New South Wales have been through that. There are case studies around sepsis, but we also then have some standalone resources, and most of these you can get from our website, and the link's there at the bottom of the slide. I mean, there's range from posters. We love videos. We have numerous videos. Ryan Thomas was a winner a couple of years ago or last year of the Amazing Race, so now we talk about the Amazing Race against sepsis. He's my star. And we also have some nifty little 5-minute videos, so if you want to know a bit more about lactate, 5 minutes, really, really quick, and it's one of those animated ones that make you feel a bit sick as you follow it, but it's really good. So, with all of that in place, how have we done? Just to show you, it's a great opportunity to show you how we're going with between the flags. As you can see here, our rapid response rate has risen enormously in the time since it was started in 2010. So it's gone up 152%. So that's a fantastic result. Concurrently, we've had a fall in the cardiac arrest rate. It's down 36.1%, down to around 0.67 per 1,000 separations. So we're really happy with those results. Within that context, then, we've got the Sepsis Kills program. Our key measure is the time to the first antibiotic. So time zero is measured in the emergency department from the triage time, or if it's in the ward, from the time that the clinical review or rapid response call is made. We have an online database, and that's enabled our clinicians to put the data in so that they can benchmark against hospitals. They can see their own results over time, but also benchmark with hospitals in their local health district and at statewide level. And currently we've got about 28,500 cases in there, which is a significant workload for the clinicians. So if any of you in this room have entered data, thank you. So as you can see, we've reduced the median time to antibiotics to less than 60 minutes, which was our aim, and it's been down since 2013. Obviously, there's going to be outliers. That's only a median. So this chart shows you what that looks like in the 1-hour blocks. What we're pleased to see is an increase in the 0 to 60 minutes and then the 61 to 120 minutes. So most of our patients are getting their antibiotics within the first couple of hours. And that fits quite neatly with our red and our yellow zones and how we would want things to happen. There is still some outlying there, and we really encourage the local facilities to look at those cases and find out what happened. In January this year, we published a paper, and I'd like to take this opportunity to acknowledge Tony Burrell, who was the main author. Tony was the previous director of the programme, so he and I worked on it from 2010 together, and he was very pleased to get to the end. He retired, and I'll mention him again in a moment in relation to age. But the results that we had... The results, we linked our data, so the CEC sepsis database was linked with the population-based data. That has some limitations in the methodology, but it gave us an opportunity to look at the outcomes. And we're really pleased to see that the overall mortality was reduced from 19.3% down to 14.1%. Now, those numbers sound really, really good when you compare them to what you might see in the literature. But I should point out that it's for the whole spectrum of sepsis, so sepsis, severe sepsis and septic shock. Much of the stuff reported in the literature is just severe sepsis and septic shock, but we're still very happy with that result. We also saw a decrease in time spent in intensive care and mean length of stay. And the number I don't have on here, which relates to Tony, is the fact that if you're over 65, which he was when he left us, you're 3.3 times more likely to die. So just bear that in mind when you're looking at your elderly patients. Just a couple more slides around the results. One of the really interesting things we did was look at patients with severe sepsis and looked at their journey in intensive care and then in the ward, because many of our patients didn't go to the ward, didn't go to intensive care, they were sent to the ward. In fact, 1/3 ICU, 2/3 to the ward. And the mortality in ICU didn't change a lot over time. It certainly wasn't statistically significant, but I still think it's quite a reasonable decrease. Interestingly then, the same happened in the ward. So patients with severe sepsis, and some of these patients had low blood pressures that really you would wonder why they were sent to the wards. They actually did reasonably well, although some died. But what is concerning is that patients that went to the ward, which is a much bigger cohort, over 4,000 patients, who had uncomplicated sepsis, we actually had an increase in the mortality, and we wonder why that is. We do know that patients with less severe sepsis make up the majority of deaths, as there's in Lou's paper. There are a number of other papers that also reflect that. What we found from experience, though, was that patients were being transferred quite well from the emergency department after their initial resuscitation, sent up to the ward, where it may not even have been handed over that they had been on the sepsis pathway. We fixed that now by making it a medical record form, so it's in their notes. But the ward staff weren't necessarily aware of that. And so they were falling off the patients were falling off their perch quite quickly. In fact, a study by Glickman said that 17.2% of the patients deteriorated to septic shock within 72 hours of transfer, with normal observations on transfer. And it really emphasises for us the importance of our rapid response team, because we need them to pick up at that point. But ideally, we'd prefer it not to happen. And just one last thing, we think there is a lack of awareness also about the significance of a high lactate. We knew from fairly early in our program that a lactate of 2 or more had a huge mortality. As you can see with the one that's highlighted here, a lactate of greater than 2 and a blood pressure above 90, the mortality is really rising. Once you get to a lactate above 4, the mortality is greater than septic shock. Our final improvement learnings, I think, would apply to any program that's being implemented in a hospital. But particularly, I think, important for us has been implementing with the Between the Flags program, also linking to antimicrobial stewardship and really working very closely with them to make sure there isn't overuse and abuse of antibiotics. Getting that culture right and making sure places are ready to implement. There's no point forcing something on them. This wasn't a mandatory program. That flexibility and flexibility to change the tools. It's only recently that we've had a standardised tool that can't be changed anymore, and clinicians have really liked that. Having data to measure is so important. We're working now, because it's often person dependent and quite onerous, we're working on an alert in the EMR. And finally, you should celebrate success and spread the news. And I'm going to make the last words from a clinician and a patient. If we could dim the lights, please. Oh, sorry. Speak. He's not going to speak. Is it possible for you to play the video from the back, please?
Are you worried about your patient? Are they getting worse? Always have in the back of your mind, could this be sepsis?
The doctors and nurses recognised the signs early, and I survived sepsis. Sepsis kills.
Time is life.
Thank you.